Overview of the U.S. healthcare system, analysis and comparison. The U.S. healthcare system. The objectives for this presentation are to provide an overview of healthcare in the United States, including some of the major developments that have influenced how healthcare has been provided and obtained and paid for, and how technology has affected healthcare development. I will also describe the roles of many of the participants in the healthcare system, from patients to providers to legislators, show some of the differences between the American system and Venezuela's system, and touch on possible future developments. Part 1. Overview of the U.S. healthcare system and history. Medicine in the 1700s in the U.S. was speculative and largely based on superstition and folklore. The Pennsylvania Hospital was established in 1753, followed by the establishment of a medical school in Pennsylvania in 1765. George Washington died of epiglottitis in 1799 in his home in Virginia, under the care of the best physicians of the time. The remedies performed by his doctors were a series of bleedings and blisterings, which had no evidence to support their effectiveness. Some scientific study had been explored, and some physicians were using knowledge of anatomy gained during post-mortem dissections of human bodies. Still, knowledge of cell biology and infectious processes would not be gained until 1838. This discovery would lead to the development of antibiotics and vaccinations. In 1789, John Adams signed into law a bill that would provide hospitals for treatment of sick and injured seamen in the U.S. Merchant Marine and Coast Guard, with funding contributed by the individual beneficiaries themselves. This is an early example of a publicly run health insurance program. Dr. Nathan Davis founded the American Medical Association in 1847. According to Wisniewski, Hayes, and Vinal, Davis's goals were to promote the art and science of medicine for the betterment of the public health, to advance the interests of physicians and patients, to promote public health, to lobby for legislation favorable to physicians and patients, and to raise money and set standards for medical education. Although official membership to AMA by practicing physicians has waxed and waned over the years, there is no denying that great advances in healthcare in America were spurred on by this association. Soldiers on both sides of the American Civil War suffered unprecedented casualty rates, and many more soldiers were dying of wound infections and battlefield illnesses than were dying of actual initial combat wounds. The United States Sanitary Commission worked to improve the sanitation of hospitals and other settings where patients were receiving care in order to minimize unnecessary deaths from secondary infection. Much was learned about the need for additional personnel to provide direct care. The need for nurses on the battlefield and in hospitals was greater than ever, and this period saw significant growth of the field of nursing as a profession. It was at this time that Clara Barton founded the Red Cross. Public sanitation and mass vaccination efforts in America worked together to significantly reduce the incidence and virulence of disease in the mid to late 1800s. Lessons learned during this period helped to cement the ideas of disease prevention and public health, which helped form the foundations of a healthier society today. As more vaccines were developed, the Centers for Disease Control and Prevention, CDC, and the World Health Organization, WHO, worked to reduce and or eradicate diseases such as polio and smallpox throughout the world. In an effort to alleviate the effects that the Great Depression had on America's poor, Franklin Roosevelt passed legislation to fund such programs as Social Security and Medicare. The Wagner National Health Act of 1939 gave support for a national health care program funded by federal grants to states and administered by states and localities, which eventually became a program for national health insurance. Scottish bacteriologist Alexander Fleming discovered penicillin which was first used in mass amounts on Allied soldiers during World War II, dramatically reducing the incidence of death by secondary wound infection. In the 1980s and 1990s, it had become evident that the complicated third-party payer system in America was not only too expensive for consumers, but was also plainly out of reach for many of America's working poor and impoverished. With help from the First Lady Hillary Clinton, and with cues taken from the successive systems in countries such as Canada and Australia, President Bill Clinton attempted to pass a massive bill overhauling much of America's health insurance programs and establishing a centralized government-funded system for those who cannot afford health insurance. Due to massive resistance in Congress, particularly from the Republican side of the houses, the bill did not pass, and this represented a significant failure for the Clinton administration. Although the Patient Protection and Affordable Care Act passed in 2010, it did not pass exactly as it was originally written. The constitutionality of some of the central provisions were questioned by Congress and tested in the Supreme Court. For example, in order for the system to effectively keep costs down, it was deemed necessary to mandate that all Americans purchase insurance coverage of some kind. Additionally, some unfair practices by insurance companies, such as denial for pre-existing conditions, were restricted under the new law. Although it was not wholly comprehensive, sweeping change as it had originally been offered, it did represent the most dramatic healthcare reform since 1965. Part 2, the cost of the U.S. healthcare system. Historically in the United States, individuals paid directly to their doctor for all services provided. Insurance-type systems were created whereby beneficiaries would share responsibility with their employer for payment of premiums to a third party. The third-party payment model gave rise to a very large, profit-driven insurance companies. The U.S. government began taking partial responsibility for providing health insurance to the retired, the poor, and the disabled in the mid-20th century. In response to public demand and in observation of the successes of universal healthcare systems in other countries, the U.S. passed the AFA to help extend healthcare to all Americans. Medicare and Medicaid are public insurance providers whose premiums are paid by taxes collected from Americans. Managed care organizations are insurance companies who try to keep costs down by setting rules and limits for utilization for healthcare services, managed by a team of healthcare providers who are paid by the insurance company. Private insurance premiums are usually paid by employers, with the employee also sharing the cost of the premium through a payroll deduction program. Cost sharing consists of different ways that the cost of the health care is paid, such as co-payments and deductibles that the patient is responsible for paying. In the United States, new medical technology is constantly being developed, such as advanced imaging and robotic surgeries. Americans are accustomed to being able to choose what they feel is best for them, so Americans frequently demand the very latest technology that is available. If they learn that they are not getting the latest tools technology has to offer, they are more likely to file lawsuits when there are unfavorable outcomes. For this reason, doctors usually comply with demands for the latest tools available, even before the tool's usefulnesses have been demonstrated. The cost of healthcare in the U.S. rises more sharply than the quality of healthcare in the U.S. does. Part 3, Healthcare in Venezuela for Comparison and Contrast. Prior to 1999, the vast majority of money going into Venezuela in exchange for barrels of petroleum was used to line the pockets of the aristocratic leadership of the nation, while Venezuela's citizens wallowed in poverty and had little access to health care. President Hugo Chavez was democratically and popularly elected to office in 1999 and served until his death in 2013. Although his administration was very unpopular among Americans, he was a man of the people, using money from the sale of petroleum to fund public services in Venezuela. He partnered with Cuba to provide physicians for underserved rural areas and opened free clinics. Although 1 in 5 Venezuelans still had private healthcare insurance, most received free, publicly funded healthcare. Unfortunately, the decline in petroleum prices over recent years has exposed a glaring problem with Chavez's funding plan. Hospitals and clinics are now understaffed, underfunded, and undersupplied. Many of them have even been shutting down because they cannot afford to stay open. Since 1 in 5 Venezuelans possesses private healthcare insurance, they have access to the elite healthcare system on par with the best the United States healthcare system has to offer. For this reason, many physicians who had grown accustomed to only providing care to the wealthy have expressed opposition to the public system, stating that the system Chavez put into place is bankrupting the nation, while still failing to provide basic services to Venezuela's citizens. Currently, family members of patients commonly must leave the hospital to search for supplies and medications on the black market and bring them back to the doctors and nurses in the hospitals for use on their loved ones. Operating rooms stand empty and unsupplied, with fewer than 50% of the country's ORs operational at any one given time. All of this results in long waiting lists for surgeries for Venezuela's citizens. There are many similarities between Venezuela's healthcare system and the United States healthcare system. For example, the wealthy in America have access to private doctors and concierge practices and can pay out of pocket for elective surgeries. Additionally, those with private health insurance through their employers pay a greatly reduced premium for their benefits. The U.S. federal government also struggles to meet annual budget demands due to an aging baby boom generation. However, since the U.S. began Medicare and Medicaid in 1965, the system is well established in American politics and will continue to be a very high priority for funding into the future. Furthermore, funding for emergency care in the United States continues to be a priority, with state and federal governments frequently providing emergency dollars annually to keep these services open and available to the public. Part 4. Reforms and Improvements. Although more Americans have access to health care since the HCA was passed, many Americans have increased coinsurance through larger gaps in coverage, larger copayments, and higher premiums. The increased complexity in knowing when gap coverage might be appropriate has proven difficult for many to navigate, and many, in fact, change each year for certain individuals. Third-party assistance in the form of Medicare.gov, the Medicare and You Handbook, and the State Health Insurance Assistance Program Network have responded by increasing their availability and their knowledge base for Americans looking for smart coverage solutions. As the United States healthcare system moves forward, lessons learned from the successes and failures of other systems worldwide will shape decision-making with regard to pay source and general health maintenance. Americans will become more comfortable with the idea of universal healthcare, and the systems in each state will become more effective for the consumer. With better access to healthcare for all Americans, the hope is that an increased focus on wellness will lead to education in avoidance of illness through exercise, healthier diets, preventative care, and the subsequent avoidance of emergency care. All of the above will lead to cost saving in the overall system.